Thank you for joining us today to discuss visualizing performance gaps in healthcare data. My name is Scott Everett. I am the Vice President of Analytics Solutions with Practical Data Solutions. I'm here with Kelly Constantinetis, who is one of our Senior Business Intelligence Programmers and Analysts. And we've got a good webinar for you today. I have been with Practical Data Solutions 9 years this month. And I have had previous experience in healthcare for about 18 years, working primarily on the finance, IT, and clinical operations side of the house with multi-specialty large medical groups. I'm joined today by Kelly Constantinetis. And Kelly, if you could just take a second and introduce yourself.
Sure. Hello, everyone. I worked for hospital and physician finance practices, both finance and application support, for about 12 years, and now I've been with PDS for just over 3, and primarily working with the clients to implement the various analytics solutions, and I think we work pretty closely with them to fine-tune and optimize the solutions.
Thanks, Kelly. So let's talk a little bit about visualization. Visualization is becoming one of the key terms and trends in the analytics industry that's out there, and a lot of these tools have similar capabilities to be able to take data and not just look at data, but be able to better understand it by quickly and easily identifying trends and outliers, to apply filters at a department, division, or provider level, and then highlight maybe some outlying data points to, again, filter down and look into what's going on and why is it going on. In this particular visualization, we are focusing on chronic care management and patient risk acuity scoring. And so you can see here by looking at the different areas of patient risk acuity categories, the patient risk summaries, the number of patients that are involved, and the different types of conditions that may go into this. A lot of the analytical tools that are out there can perform functionality like this, and what we want to talk about today is how we can take a tool similar to what you're seeing here and apply it to identifying performance gaps within your practice. So our goals for the next 50 minutes or so are to define what really are performance gaps and what are some strategies to help really identify bottlenecks, to identify problems within your organization, and how we can utilize these visual tools to make that process quicker, easier, and make the communication a little bit more effective. We also are going to focus in a little bit on lags and how improving lags can not only improve your cash flow, improve your practice's bottom line, but also improve the overall patient experience for those who you're working with. So before we dig into the webinar, we'd like to take a quick survey of those of you who are joining us today. So if you could just pull up this survey, what we want to look at are your individual organization. Where are you most focused in looking at performance gaps? Is it, in quality and adjustment scoring? Is it patient access, revenue cycle, or physician compensation, which we're seeing a lot more going on with some of our clients? Oh, this is really interesting that we see a lot are getting into the quality and risk adjustment scoring, and this is certainly something we've seen with a lot of the clients that we work with. Obviously, all of the above is what I would expect to see, that a lot of our clients are really focused in on a lot of different areas, and it's hard to identify problems when you've really got a lot of balls up in the air and that you're juggling. So thank you for participating in that. So let's talk about what we mean when we say identifying performance gaps. A performance gap is the difference between where you are as an organization and where you want to be as an organization. And there are a lot of things that could be coming into play that are keeping you from getting to what is actually intended, or the situation that is most ideal for your practice. So when we work with clients, a lot of times what we tell them to do to begin the analysis is start with setting some meaningful goals. And what we mean by meaningful goals are what are things that you can control, what are initiatives that are strategically critical for your practice, and what are things that you feel that you could put processes in place that you're prepared to invest time and resources into correcting. Now, once you set these goals, you want to benchmark your current state. It's really difficult to figure out how to get to where you want to go if you don't really know where you are. And benchmarks can be both internal or external, but really you want to understand where you may be lagging in certain critical areas and start analyzing not just what's going on, but why is it going on. Start really digging in and trying to understand where the bottlenecks in your organization may exist. Is it a people issue? Is it a process issue? Is it a technology issue? Is it maybe all of the above? And that's when you can really start putting in play new processes, really driving change in order to realize the financial benefits that can come from this. Well, how can we visualize these gaps and really understand where they are without having to spend a ton of time pulling a bunch of data, digesting a bunch of numbers, doing a bunch of different calculations? There are really quick and easy ways to find that low-hanging fruit that may be out there in your organization. One of the ways we talk about is through spikes or troughs, and that's just looking at trends and finding things that are outside of the norm. Outliers obviously are big keys to understanding, are these outliers really dramatically impacting the whole, or are we just having a onesie-twosie type things here that just need simple correction? And again, talking about benchmarking and financial impact can be a way to really provide compelling arguments for managing these changes. So let's look into what we talked about with spikes. Okay, a spike is something where you can draw a quick trend of a specific metric. In this case, we're looking at denial count. Okay, you can look as we trend across a 12-month time period that in 2 of the months there were definite spikes that can be seen easily in this trend graph. And while the trend overall trended in the direction we'd like to see, something definitive happened during those months where those spikes were. And we want to analyze and dig in to better understand what happened there. Was it a one-off situation, or is it something that needs to be corrected more strategically? So what we can do in situations like this is open up an analytical tool. Now, there are a lot of analytical tools that are out there that can perform analysis like this, but this is something where you can go in and look on this trend, and you can see, say in January, you can see how there was a large spike in our denied charge amounts that was very much outside of the norm. So if we want to filter on that particular month and really start drilling in and trying to understand what happened, is it a specific payer issue? So we can bring the payers across and really look at individual payers or payer categories and say, okay, as we scroll through, it looks like the volume really very heavily lay in our Blue Shield pair. So applying another filter, and we can dig down into another selection. We can slice and dice and say, is there a particular division where this occurred? Did it happen in family practice? Doesn't look like the volumes are real high there. Let's look at, say, hematology. Oh, there was a significant spike in hematology that was there. Let's pull in our denial types and look at, what are the specific denials that may have been feeding into this, and you can see that there was a lot of denials that occurred in our process type denials. We can drill into the individual codes if we need to, but more importantly, we can drill down to the individual detail of each invoice that fed into this, so that we can see, is this a pattern that occurred, or is this something that there was a very broad spike that may be more problematic to solve? This is what we mean when we say analyze spikes and analyze the one-offs. This is a very easy way to identify performance gaps in something like denials management. Now, spikes and troughs can be seen in other areas as well, and I know, Kelly, you've been working in other areas and seen things like that. Could you maybe give us another good example?
Yes, Scott. So we've seen a lot of clients start looking more and more at, and wanting to dashboard some of their clinical measures. And here we've taken a subset from our higher risk HCC population that we looked at earlier, and looking at clinical measures specific to our diabetic patients. So from this trough chart, we can quickly tell by glancing that we're pretty successful at getting our hemoglobin A1Cs ordered and completed. But we can also see from the visual gap that's highlighted that we've got a bit of work to do when we are trying to complete our eye exams and getting those up to the target that we're trying to meet. And Scott, I know we've got a couple of physician compensation dashboards that the team's been working on that call out some potential performance gaps.
Yeah, no, this is definitely the case. Physician compensation is changing a lot in a lot of different organizations that are out there, where it used to be fairly simple to take a visualization tool like this and look at, say, the lower RVU productivity and understand, where our lower performing providers were and address maybe productivity issues with them. But more and more as the industry changes, people are starting to add incentive pools related to quality or satisfaction or access, and understanding where these gaps may lie in both of these areas by highlighting, you can see right away that there is a significant gap in the work RVU productivity, where there may be lower compensated providers that have higher productivity, but because they're not meeting their incentive pools, it's causing a lot of differential between what the calculated compensation is and what the actual compensation is. And so if you look at a department like family practice, where you can see a fairly significant gap between the salary that's actually paid and what is calculated, this is something where you're going to have to address with the providers differences in the way that they're doing business in order to really be optimized with their compensation as the new models come into play. So identifying outliers, particularly in something like physician compensation, can be key as well. One of the things that you can do if you're still just in a productivity-based calculation for productivity is you can identify outliers by looking at a quartile chart like you see here, where you can look at your higher performing providers or your higher salary providers and look at those providers that may be in a high salary for a low productivity quartile. This is something that allows you to really focus efforts on what you're trying to do in order to manage these gaps instead of having to put in place some sort of blanket policy. Now, when we talk about quartiles and percentiles, obviously we're implying utilizing benchmarks that way. And again, we can be using internal or external benchmarks. But Kelly, I know you've recently been doing a lot of work on that. Can you talk about some of the work that you've been doing with visualizing benchmarks?
Sure. So whether you're trying to benchmark against an industry standard like HFMA or FPSC, or if you've set internal goals for your organization, or if you're comparing yourself to past performance or setting that baseline, like you indicated earlier, Scott, we can use these trend indicators that will quickly call out any gaps at a quick glance. So in this example, I can really quickly tell that I'm not meeting my benchmark or my goal that I've supposed to be meeting for that first metric of days in AR, based on my red indicators. So now in this particular dashboard, we go with a straight yes or no, good or bad, but you may want to build in something to indicate we're not quite at our goal, but we're really close, like within a 5% range. And so that red X might change to a yellow or a blue indicator. And here we've used view detail hyperlinks, and these have been incorporated so that users can be launched into additional key reports that might be useful when trying to determine what's driving those red X's or variances to the benchmark. So in this case, I might be launched into a report that shows my AR aging by payer or some other level of detail so that I can focus on more detailed gaps when trying to get those AR days more in line with my target. And Scott, you've actually taken benchmarking to the next level where you're modeling financial impact associated with meeting those benchmarks or targets.
Yeah, one of the things that is really kind of a fun analysis to do is not just saying where we are in relation to some benchmark that may be out there, but kind of do some dreaming and say, well, what if? What if we were performing at that level? What would be the impact to our practice? How would it benefit us financially? And you can really do this across any area where you can benchmark, any area in the revenue cycle itself. So if you look at something like this is requires some fairly complex calculations, but if you go in and look at, say, improved cash flow by reducing charge lags, you can see right away, here's the activity, here's what's going on in our organization. And then you can look at comparisons and say, here's what a benchmark or a target should be of what we're trying to get to. And then from there you can say, well, what if we were performing at that level? And what if we were performing at an internal benchmark level where every provider was performing at, say, the average of the department, or performing at the level that their peers are doing? Or what if they're performing at an external benchmark, a 50th percentile of MGMA or a 75th percentile? What would be the financial impact that we would see from that? And from that, it does a couple of things. One, it helps you to really easily identify those outlying providers that are causing the bulk of the, I guess, best way to put it, cost of doing business the way that we do it. By identifying these particular outliers, we can focus on them, again, rather than having to put some blanket policy in place that may actually even be detrimental to our higher performing providers. The other thing that this does for us is it allows you to attach a financial impact, which provides a pretty compelling evidence to drive change with these providers, to get them to change the way that they're doing things, because it can really help to improve their productivity numbers. It can improve the bottom line of the clinic or health system itself. And as we'll discuss here in a few minutes, it can really help to improve the overall patient experience as well. So now that we've talked about how we can visualize finding these performance gaps, I'd like to quickly take another survey. What are the big bottlenecks within your revenue cycle right now? Is it charges going in? Is it getting payments back from the payers? Do you have an issue with denials, or is it something else that maybe we're not discussing? This actually doesn't surprise me. Denials is a pretty significant bottleneck that exists out there, and it's certainly something that we're going to talk a little bit about today as well. But interesting to see the insurance adjudication. Usually we're finding those are starting to get a little bit more quick. However, there are more denials coming in as well. So this is good. Let's talk a little bit about improving the revenue cycle that way. So one of the terms that I learned in business school when we talk about things like lags was Hofstede's law, is that any process that you put in place is going to take longer than you'd expect, even when you take into account Hofstede's law. So why are we going to talk about lags today when we're talking about performance gaps? Well, there's a couple of reasons why lags are really critical to this. First of all, lags typically generate big gaps, and when you look at those, they are usually pretty controllable. They're things that we can put in place that are on our side of the house most of the time that will help to really significantly improve how fast we get money through the door. Now, when we talk about getting money through the door, cash flow is something that's really critical. And the way I like to look at it is there can be a significant return by reducing lags by improving cash flow, because if you can reduce 1 day of lag at any point in the revenue cycle, you will turn in 366 days worth of payments this year rather than 365. And for most large health systems, that can be a 6, 7, or 8-figure deal. So reduction in 1 day really brings a big benefit to cash flow. But in addition to managing cash flow, we can improve patient access across the entirety of the system. And we'll talk a lot about what we mean by patient access lag. But at the end of the day, what's most important and where reducing lags really helps is improving the overall patient experience. And yeah, this occurs even in the back end of the revenue cycle. So Kelly, I know you work a lot with lags with our clients. Do you want to talk about maybe some of the work that you're doing?
Yeah, so first I'll just talk about the different types of lags where we can measure them, from a static or a dynamic perspective. So from a static perspective, we look at the difference between two specific dates or times. And for example, we'd look at a charge post date, the difference between a charge post date to the first insurance payment date, or patient check-in time to check-out time. So we're looking at static lags there. With dynamic lags, we're really looking for our lag days to change from one day to the next. And typically this is how we would measure our aging receivables. So for each charge that's sitting in my receivables, it has the potential for the age or the lag to increase as each day passes. And in general, we say that lag increases and it would have a negative impact on your revenue cycle. And I think, Scott, you were just talking about cash flow. Haven't you told me cash flow is queen?
Yeah, something like that, Kelly. Cash flow is something that is really preached in any business setting that's out there, because really you can have all of the revenue you want, but it doesn't do you any good if you're not turning it into actual spendable money. I found working in finance right away that you can't pay a salary with a receivable, and you can't negotiate a vendor contract with a set of claims that are still outstanding out there. And don't think I didn't try. The point is trying to get the revenues that we have to generate cash in order for us to invest in our organization and really help us to do business the best way and most efficient way that we can.
So it used to be that we would measure, the famous charge lag. We would measure it between the date of service and when the charge was posted. Well, now we've got more front-end claim scrubbers, and we have charges sitting in these front-end systems. Although we may not be adding days to our charge lag overall, we really have the need and the ability to get to a more granular level to determine at which point in the charge capture process might be causing extended lag times. So is it the difference between the service date and the date that the charge was entered into that front-end system, where it would indicate a lag on the clinical side or some sort of front office delay? Or do we have that lag, greater lag between the date the charge was entered in the system and when we actually drop the bill? And that would indicate we've got an issue on the CBO side or with that claim scrubber. So we have our little entertaining scenarios here where we were playing golf and we're only working 3 days of the month. But in reality, as we start slicing and dicing the data, you can get down to where those lags are occurring. Are they with specific departments, providers, or even with specific procedure codes that we're having trouble getting out the door? Are we always waiting on documentation for surgical procedures at a certain hospital, or are we waiting on authorization numbers from a certain payer? And so we can take a look at a visualization that we can really start to see what sitting is out in that unbilled AR bucket. And just by looking at this real quickly, I can see that in my 31 and over days, that looks way too high to me. And so I want to deal with those dollars first if possible. And once I get those dollars segregated, I can say, well, now I can start seeing which division all that money is sitting in. And here I've got a good chunk in the cardiology division. So a big slice of that pie is related to credentialing. So if I limit the dollars down to the credentialing money, and all the way at the bottom, we can see where our providers and which providers are contributing to that credentialing issue. So is this real credentialing issues, or can we somehow get those charges out the door before too much more time passes? And I have one more charge lag report that I'd like to show quickly here. And the first time I saw this report, I thought, wow, this is a lot of numbers. And then I realized it's a pretty telling chart, and the nice thing, it's really easy to create. And we've done this in exercise in multiple different BI tools because of the ease to create it. So you just simply need your service date in the rows on the left-hand side and compare that to your charge entry date across the columns on the top. And the measure that you use, you can either throw your claim count in there, or you can throw your just a procedure count. And the idea is that you'll get those numbers, the bulk of your volumes, to fall right on that diagonal where the thumbs up guys are standing. And you'll see in that 264, we had date of service was October 7th, and the charges were entered on the 8th. That's right above my line. That's right where I want those charges to fall. Anything that gets further away from that diagonal on the right, it's going to indicate I've got bigger issues with charge lag. Anything below my line, that's going to indicate I've got something going on where I'm entering charges before my service date. So those are suspect that you want to maybe take a look at. And as Scott, I've talked a lot about charge lag. But of course, that's only one piece of the puzzle because now we've got to get paid.
Yeah, and, and ideally getting these charges out the door is great. We want to get the payments back in the door as quickly as possible. And so there are all kinds of different payment lags. I used to tell people when I worked in finance that they would complain about certain payers of, payer X just pays terribly. Or I say, yeah, but they do it fast. And there's really something to be said for that, because getting the payments back and getting that cash back, even if the reimbursement rate's not necessarily ideal, it can actually be more beneficial to you than, say, other payers that may have greater rates that play a lot of games or get the payments back to you much more slowly. So looking at your overall payment lags and how long it takes to actually get paid can be a fairly important lag to note within your organization. So is it something where we look at the time it takes the first insurance payment to come back to us, or is it something that we're struggling to actually zero out the invoice balances that are there? And when we talk about zeroing out today, as we note with lots higher deductibles, co-insurance, and co-pays, a lot of times what the length of time it takes to zero out these claims is what it takes for us to collect from the patient. So if we can collect those up front, if we can communicate with the patients their responsibility, a lot of times what we find is that we can find some significant payment lag drops by simply communicating better with our patients. And what's more, our patients prefer that because they don't want to have to be surprised and wait as they get billed for what they know is their responsibility. So payment lags is something that's very similar to what we saw up above, where it's really good to benchmark this and put some what-if scenarios in place, because you'll see a couple of things. One, not only when you get paid faster does it impact your cash flow, but as you get paid faster, your collection rates will increase. It's much more difficult to collect those claims that have been aging a long period of time than it is for the newer claims. So the faster you can get paid, the greater your reimbursement rates overall will be. Now, of course, one of the things that really drags down payment lags or zero balance lags is when we get into denials. And denials is a fairly significant problem that we work with a lot of clients on. And one of the things that we look at when we are looking at denials management are the different lags that are out there. And again, it's how long is it taking the payer to get back to us with the denial? Is it something where we're bordering on timely filing claims with the time they get back to us, or is the main lag on our end where we're getting the claim back in a reasonable amount of time, but it's taking us a long time to collect the documentation and file the appeal and jump through all of the hoops that we need to do in order to get a payment from the insurance? And again, when we talk about denials, a lot of people don't realize this because it seems like an insurance issue, but denials really can be a patient satisfaction issue as well. And where it gets into a really big area is when we start talking about everything that we do with the payers to finally get an adjudication, and then we're now 4 to 6 months down the road billing a patient for a service that occurred several months ago. And so really tracking these claims is helpful because patients don't like to be surprised with financial responsibility that they weren't aware was out there. And so driving down denial rates and driving down denial lags can not only improve your organization and what you're doing, but also improve your patient engagement, particularly with collecting the patient balances that are out there. Now, one of the things we talk about with visualizing gaps, especially in the area of denial, is we call it getting quick answers. And there's so much data out there that you can get into regarding denials. What's really important is to understand just a few key strategic areas in denials management and not have to digest a bunch of numbers, but be able to really easily understand where you are with regard to your trend. Are you better in your denial rates this year than you were a year ago at this time? Are you getting payments back from your insurance carriers faster? Are your appeal efficiencies higher? Are you getting paid better after the denial? Are you cutting down on the denials that are your fault versus denials that are the payer's fault? And are you doing the things that are within your control to drive down your overall denial rate? a visualization like you're seeing right here can help you identify spikes, trends, and look at areas very easily and understand here's where we're doing well, here's where we're struggling, and these are the areas that need to be addressed right away, and these are areas that need to be addressed more strategically. So we've talked about charge lags, we've talked about payment lags, we've talked about everything except for the really, really important part of the revenue cycle that everybody talks about that is a lag but isn't termed a lag. So Kelly, what are we doing with AR out there?
Yeah, so how long do we have things sitting in AR after the bill is created and after we bill the insurance company, or after we think we billed the insurance company? So it's of value to measure the AR from different points in time, and this goes back to the dynamic lag perspective. So we want to measure it from service date because are we going to run into timely filing issues? We want to measure it from the bill date or when we drop the charge because, you know, that's really when we can start expecting to see some money back in the door, and oftentimes this is what, you know, our general ledger reserves are based on. And then there's value also in looking at your AR from when it was transferred to the most recent payer. So when was it transferred to self-pay? When was it transferred to Medicaid, et cetera? So if we can look at a visualization of our aging AR, and this top section indicates, you know, how long it's been sitting with the current payer. And then I can limit that if I look at just my 2 and 3 months. So maybe that's a good chunk of money sitting out there for my organization in that 2 or 3 months. And when I limit that and I can look at that by payer, I would expect to see that things that have been transferred into self-pay in the last 2 to 3 months still might be sitting there. We've got higher deductibles are a challenge for people now. If we limit to the Blue Cross payer, we can see that even though this has been sitting with Blue Cross for just the most recent 2 or 3 months, if I look down at the bottom of the chart with the original age of that payer, some of that money's been sitting out there five months or more. So this could indicate that I need to take a look at those particular bills. Did we have some sort of event with that? Maybe a secondary payer, maybe a set of denials came through. But either way, we might want to look at that group of claims before they age out much further. And then we can move on to, we want to survey on patient experience and patient engagement. And where are you finding the greatest gaps in improving your patient experience or patient engagement in your practice?
Not surprised to see patient access is something that people are seeing and having difficulty with. Certainly something we're working with a lot of clients to help them measure and identify gaps. And really it's no surprise because when you look at patient engagement, patient access really is truly a critical area in the revenue cycle. So why is patient access so critical? Obviously, this is something that goes to negative outcomes, and obviously patient satisfaction is a critical issue. But this is moving more and more towards something that you're going to be compensated on by payers as value-based reimbursement comes more and more into play. It's something where not even your actual access, but the patient's perception of your access is going to be something that feeds into your contractual reimbursement that comes back from the payers. In addition to this, you can look at patient access as something that drives higher costs of healthcare within your organization, as you have ER crowding, as you have more negative outcomes from patients who have to wait longer to get into see providers. And so patient access really is kind of a critical thing that, like I said, a lot of our clients are looking at. And what do we mean when we talk about patient access? What's important? Obviously getting patients through the door. But I think when we look at the overall patient experience, it's not just getting patients in the door, but we also need to understand what's going on with the patients while they're in the clinic and getting them back out the door and onto their lives, their better, healthier lives, rather than having to spend their entire time waiting in the clinic. So when we talk about the different lags that are associated with patient access, obviously, appointment lag, or the difference between the date the appointment is scheduled and the actual appointment date, is not just a patient satisfier, but it's something that can drive satisfaction and competition with your referring providers as well. Referring providers will find different providers to go to if they are not able to get their patients into your specialist in a timely fashion. So really understanding the lags and understanding how well you're doing at getting patients in same day, 1 to 3 days, within a week, or what's taking longer than 30 days to get in are some things that are critical. But again, talking about what goes on within the clinic itself are, from a patient engagement standpoint, really critical to understand how well your patients perceive the efficiency and effectiveness of your organization. So we can look at a visualization in patient access, and you can see here that this shows that our appointment lags. We have a lot in that greater than 30 days. This is a family practice graph. But that greater than 30 days could be being driven a lot by, if we're family practice, wellness visits that are scheduled a year out, or follow-up visits that are scheduled 3 to 6 months out. So let's just focus on new patient visits. Those are ones where we want to get them in as quickly as we can, but it's not necessarily an emergent situation. And you can see the distribution is much more reasonable, much more like what we would expect for this type of patient. So that's in family practice, but are our specialists doing as well? So if we look at something like gastroenterology and trying to understand what's feeding into that, we can see that gastroenterology does have that greater gap in the greater than 30-day new patient visit lags. Okay, well, what could be feeding into that? As we look at, appointment status, it doesn't look like they have an unreasonable no-show or cancellation rate. There's a pretty broad variance in the provider's third next available. However, you can look right away and see in scheduling utilization, there's really only 2 days a week in which the utilization of the templates or the schedules are being optimized. And this is something that can definitely be addressed fairly easily by helping to understand, is this a provider issue where they're blocking off more time than necessary, or is it a patient issue where we're not necessarily having our availability of providers at times when the patients would demand to be seen. So this is another example of identifying gaps, but looking at the interplay between the measures to really understand why the gaps are showing what they're showing. So Kelly, we've talked a lot about getting our patients in the door, and I know you've been working quite a bit with clients and something that's really fairly new in measuring these clinic times. So what are you looking at there?
Sure, Scott. So you've been in a doctor's office and had to wait, or you've been to your doctor's office and someone who's there with their 5 young children has clearly been waiting a while. So whether it be the increased use of health records where they're kind of driving the flow of the patients or driving processes around the patient flow, whether people are more and more concerned with measuring the wait times that people are encountering in their practice due to competition or just the patient experience. But we're starting to see more reliable information as it comes to the time the patient was arrived, the time the patient went to the room, the time that they saw the provider, and then the time they were checked out. So really those cycle times that we're seeing, they're starting to be tracked a little bit more reliably. And we're able to start providing this data to end users. And we've got an example of a cycle time dashboard where we can start to group up our wait time by area. So are the patients waiting in the waiting room? Are they waiting to see the provider? Or is the bulk of the time being spent with the provider? So we can group those up so we can focus on them in groups and then notice whether or not specific providers are spending more time with patients. We can drill down to get to visit types if necessary so that we can see, well, for a follow-up patient, we're falling into the realm of what's acceptable where they're only in the office for 20 or 25 minutes. And then our procedures might be in the practice for a longer period of time in the 90-minute to 120-minute range. So, Scott, with all the time patients are spending in this practice, we have plenty of time to collect co-pays and outstanding balances, right?
Yeah, it's definitely there as long as we make sure that we're communicating that effectively with the signs that they're seeing every 3 feet in the clinic as they come in. Really, when we talk about this, communication really is the key with our patients. And when we talk about patient engagement, what we want to talk about is, are we communicating effectively, and is that communication 2 ways? So there are some lags that really show where we could have some gaps in patient engagement, and one of that is in our cancellation rate or cancellation lag. Are we getting notification from our patients when they can't make appointments, or are they not communicating back to us, which really can provide some gaps in our schedules and our overall provider utilization. We also talk about getting those signs out there so that patients, we're communicating with patients the expectation of their portion of the healthcare that comes across. And then really, are we able to get them back in? Are we able to help manage their chronic conditions and have the continuity of care so that they're receiving the quality of care that they deserve?
Yeah, Scott, so we've got a slide here that shows where we're capturing how well we're getting our Medicare patients back in for their annual wellness visits. So Medicare has a handful of these G codes that we can bill every 12 months. So we want to get those Medicare patients back in for their checkups. And we can see how we're doing here as reimbursement becomes more driven on managing these patients, becomes more important to get these patients in on a regular basis. And then really you're able to look at your entire population using those evaluation and management codes to see what percentage you're getting in for their annual checkups and really being able to manage their care on an ongoing basis.
Thanks, Kelly. You know, again, as we talk about all of these things, and we've talked about a lot of different things, and again, this can get overwhelming as we look at all of the potential gaps that may be out there in your organization. And so really one of the best ways we found is to really help narrow things down. There are some strategies to really help you analyze where these gaps may lie. And one of the things we look at is talk about categorizing lags. And obviously the categories are going to differ by the type of lag. You want your clinical cycle times to be measured in minutes, where you want your AR and denials management to be measured in months. But looking at these individual buckets can help to identify spikes and can help to identify problems and can help you identify trends of, are you going in the right direction or the direction that you would expect to see based upon the initiatives you're putting in place. You don't necessarily have to look at a bunch of different numbers that are out there when these categories will really provide a lot of great insight. Additionally, we talked a lot about outliers. And outliers can really bring about a lot of return, 80% of the return for 20% of the work. So find ways to look at it, whether it's benchmarking, whether it's looking at quartiles and percentiles, or whether it's just looking at spikes and troughs in comparison of providers to each other. So what are some of the things that have been critical to you?
So what do we exclude from our lag calculations? So as we start providing this data to end users, and we're reporting lags, which indicates something bad or a problem, so it's a little more scrutinized. From a charge lag perspective, we're always going to have these charge corrections or charge voids. So typically we'd want to give credit for that charge and the lag associated with it on the first time around, so that 3-4 months down the road, when we realize there's an issue and it has to be voided or charge corrected, we're not double hitting that charge for any sort of lag. And then the question is, do we exclude weekend days? A lot of times from a charge entry or charge lag perspective, people want to exclude those non-business days. When you get into the calculation on appointment lag, so if a patient calls on a Friday afternoon and we can see them on Monday, that seems like a pretty good lag. We can get them in one business day, really. But from a patient perspective, is that really the expectation with the increase in urgent cares and some competition from your CVSs? Is that still acceptable, and is it appropriate to exclude those weekend days? So we've jumped around quite a bit throughout the revenue cycle, but I think we've covered a lot of being able to identify some gaps all the way from your patient access perspective back onto the denials and AR. And at the end of the day, communication can probably be a key factor in all of this.
That's definitely the case, Kelly. I think we've said it 100 times today, and it can't be overstated, is that everything that we're doing here, communication is a key. And it's communication with our patients, it's communication with our management, it's communication with our providers to be able to show them where are our greatest performance gaps. There's a lot of potential out there to find gaps, and it's really critical to be able to quickly and easily identify where our greatest opportunities lie. So you can look at ways of doing that, whether it's trend indicators or whether it's big red, yellow, green cells showing what's there, applying your visualization tools to filter and sort, to really dig down, slice and dice what's going on, why is it going on, and getting that information out to the people who have the power, who have the authority, and who have the resources to be able to actually do something about it. Okay, well, I want to thank everybody for your time today. We appreciate it. And as always, if you need to get a hold of us, our information is available on the screen. Thank you.